Good afternoon, everyone. Welcome to our webinar this afternoon on following and understanding your Freelite chain test results. I am Gabriele Colasurdo. I'm the Manager of Education and Patient Services at Myeloma Canada. Before we get on to our presentation, as I usually do, we'll go over a few things. Firstly, I'd like to thank our sponsors, Amgen, Binding Site, BMS, Janssen, and Takeda, for providing us with unrestricted educational grants that helped make these webinars possible. Next, I see a lot of familiar faces here on the webinar. As you see, we're really ramped up our virtual learning program because of the situation that we're all living right now, and so this is actually part of a presentation that would have been given at our national conference. Actually, no, that's not true. We gave this presentation last year at a national conference, and we thought that we would also provide you a webinar here. Anyways, so our next webinar will be actually tomorrow, Thursday, May 28th, and we have patient advocate Yelak Biru from. He's part of the board of directors of the International Myeloma Foundation, who's going to be telling us a little bit about his story and he was I know that he was diagnosed at the age of 25, and he is now approximately 50 years old, and he's been living his life 25 years with myeloma, 25 years without myeloma. So it'd be interesting to hear from Yelak and more about his stories, and be able to ask him some questions tomorrow. I hope you guys can make it. If you can't make it though, our webinars are all recorded on our YouTube channel, youtube.com. If you type in Myeloma Canada in the search bar, you can also search from your YouTube app, either on your phone or on your tablet, Myeloma Canada. You'll find our channel over here. Clicking on the subscribe button will give you notifications every single time that we upload a new video. That way you'll be able to stay up to date with the latest. From our website, myeloma.ca, on the menu, you click on resources, the menu will open up educational videos. That'll redirect you to our YouTube channel for the videos. How to ask questions. So please send in your questions during the presentation. We're only going to answer them at the end of the presentations, but you know, as the question comes to mind, please type it in, and I'll be able to ask our presenter the question. So on your you go to webinar software. If you're using a computer, you click on the questions tab here on this little triangle. It should open up. You type in your question, you press send, and I'll receive that. On the iPad or on the phone, then you have a little button that says questions, and it's the same concept. You type in the question, and you press send. And so without further ado, I'd like to introduce you to Frank Courjal, who is the Director of Scientific Affairs at the Binding Site. Frank, thanks so much for accepting to come present with us today, and for taking time out of your busy schedule.
Okay, thank you, Gabrielle. I hope you are able to hear me very well. Yes, I want to thank Myeloma Canada that gives this opportunity to stay connected on these troubled times. I hope you are all in a cool place, because here in Quebec it's pretty hot. Today I will talk about Freelite chain, which represent an important component of your disease and serve as a biomarker, which is very useful to monitor the evolution of your disease, as you will understand later on in my presentation. And what I want to achieve with you today is to talk about the Freelite chain, is to go back to what is myeloma. You probably already know it, but I think it's important to understand a couple of some features of this disease to better understand what light chains are and why they are important. So that's what I will first do. I will go through a little bit of background on myeloma and monoclonal gammopathy in general. And after that, I will go to understand why and how we test, and we are having some results to monitor or to diagnose your disease, before going on the third part on what is the utility of the Freelite chain and why they are so important and why you have to follow them. And finally, on my last part, I will talk about urine testing, which are usually required by your physician at one time or another of your disease. And I will discuss a little bit of that to finish my presentation. So to start, we are talk about multiple myeloma. When we talk about this kind of disease, we talk about a type of cell that is the plasma cell. So the bone marrow is where all the cells develop, all the cells of the blood developed, and you have three types of cells. You have the red cells, which are the erythrocytes that produce the oxygen for your body and for your organs. You have the platelets who are involved in the coagulations and are very important when you have some injuries. And you have the white cells, as you can see on this picture, with the some cells in the T cells and the B cells that are going to produce some antibodies at one time. And the last evolution or development or differentiation of the B cells is the plasmocytes, or the plasma cell, which is a cell that will produce antibody, or what we call also immunoglobulin or gamma globulin. So these plasma cells, that's the function of this cell, is to produce this kind of protein, this kind of molecule that the shape of this molecule is a Y, as you can see, because it's done of two heavy chains in the middle that are identical and define the isotype of the immunoglobulin or antibody. So you have the G, the A, the M, the D, and the E. The G is the more frequent, it's about 70%. The A is about 15 to 20%. The M is about 1 to 5%. And the D and the E are pretty rare. Associated to this EV chain, you have some light chains that are of two types. That could be the kappa or the lambda, and that's the way you define the immunoglobulin that are produced. You can have the IgG kappa, IgG lambda, IgA kappa, IgA lambda, and all the family like that. So that's what define your disease, the kind of monoclonal immunoglobulin you develop. You have heard probably IgA kappa or IgG lambda or things like that. So that's why we have this nomenclature. It's related to these immunoglobulins. The plasma cell are in fact it's producing antibodies, and the antibodies are used to fight some bacteria and viruses. And at the current time with the COVID virus, I think that you've heard a lot about antibodies and the way to fight. So if I summarize very quickly and very simple, in a very simple way, what happens? You have B cells that are circulating in your body, and when these B cells recognize bacteria or a virus, then it multiplies a lot and produce a lot of antibodies that will destroy or help to destroy the bacteria or the virus. That's what happened for the COVID. And it's really a race between the production of a massive antibody, of a massive amount of antibody, and the replication, multiplication of the bacteria and the viruses. And that's why when you are young, for example, your replication is faster in your immune system than when you are aging, which means that most of the time when you are younger, you win the race and you are able to destroy the virus or the bacteria before it evolves. But if you are aging, or if you are sick, or if you are weak, then it's more difficult for you and you are more susceptible to develop the disease. So that's where the plasma cell play a very important role. So when you are in a normal situation, you are not sick, you are a healthy person, you are in what we call a polyclonal situation. When you're polyclonal, it means that you have a lot of different plasma cells that are producing a lot of different types of antibodies that are able to recognize a lot of different bacteria, a lot of different viruses, a lot of different foreign proteins. And that helps you to protect you for any infections. In the monoclonal situation, it's when you have one of this clone that will evolve over the other and form what we call a clone and become a monoclonal, and will produce only one type of antibody in excess over the other. So you lose this diversity of plasma cells and of antibody to recognize a lot of different viruses and bacteria. And it's due to this monoclonal situation. And usually in your bone marrow, you have between 1 or 3% of the cells that are plasma cells. But in a myeloma situation, you can go over 90% of cells that are plasma cells. So physically, it brings a lot of issues like in the bone, and it prevents the development of other cells like red cells, like other white cells, and it can damage also the bone. So that's why the development, the abnormal development of this plasma clone is detrimental for your ALC. And so the sign and symptoms are most of the time non-specific, but they are related to this growth of plasma cells clone. And for example, you have bone pain because you have a lot of plasma cells in your marrow that takes all the place and more than the place that is available for that, and so you have some bone pain and can go to a fracture. You have a lot of fatigue too because the development of red cells is not as it's not sufficient, is lower than supposed to be, so you have less oxygen to your organs and less oxygen in your body, so you feel this fatigue. The same, you can have a recurrent infection as well because the other white cells are not able to develop, and you are not able to fight bacteria and viruses. And you also related to the red cells that are not able to multiply and be in sufficient amount. You have a lot of anemia with all the consequences of anemia. So a lot of signs and symptoms associated with this clonal proliferation. And the clonal proliferation, in fact, it's not only multiple myeloma, it's a family of disease. Multiple myeloma is part of a family of disease that we call the monoclonal gammopathy. Monoclonal gammopathy is all related to the production of high level of abnormal level of monoclonal protein, but some are more detrimental than other. The MGUS is the monoclonal gammopathy of undetermined significance. It's an indolent disease. Is what we call, initially we said that it was a benign disease. In fact, it's not benign, but it's pretty indolent. You have very no symptoms to light symptoms most of the time, and that's a huge population from where all the other diseases originate from. So multiple myeloma, before having a multiple myeloma, you had an MGUS. Before having a smoldering multiple myeloma, you had an MGUS. So it's an evolution of one of MGUS to another disease that is that create your disease. And what is important, and probably the challenge for the future years, is to identify in this population the patients that have the more risk to evolve in the other population where you have symptoms and you can die of. So if you took multiple myeloma, to come back to multiple myeloma, you have in fact three different type of multiple myeloma that are related to what they are excreting. So if you take the intact immunoglobulin myeloma, it's 80% of the cases of multiple myeloma, and it's because they are secreting intact immunoglobulin. And in 90% of these cases, you have also light chain, that is the free light chain that is produced. The second type that happened for 15 to 20% is the light chain multiple myeloma. This kind of myeloma are producing only light chains, free light chains, and not intact immunoglobulin. And the last category is the non-secretory, or we call also the oligosecretory multiple myeloma. It's 1 to 5%, and they are secreting a very low level of monoclonal protein, sometimes no protein detectable, but most of the time with the free light chain assay, you are able to detect something, which is pretty important for the patients to have something to be followed for to monitor the disease. So why physicians are asking for tests, and how do I do that? There is a lot of analysis and a lot of tests that are done when you suspect a monoclonal gammopathy or when you monitor monoclonal gammopathy and multiple myeloma especially. And I have separated this assays or this analysis in two categories. One is to quantify the myeloma cells and what they are producing in one part. And the other part is what is causing the damage to the organs. Like you have some symptoms, but what is causing damage? So yes, calcium is a very good indicator or biomarker of your bone or destruction of bone or anemia. Hemoglobin is also an indicator of anemia because directly related to amount of red cells. So creatinine is related to the function of your kidney. So you have here it's all related to organs. But today we are going to focus more on the other part because that's where you are going to quantify the free light chains. That's where you are going to follow the production of your monoclonal protein. So probably most of you, if not all, have gone through the bone marrow biopsy, which is pretty invasive and not the best analysis that you would like to have, but it's the only one that can give you the number of plasma cells you have in your disease. So it's at one time or another you will have to have that to quantify and to count the number of cells and abnormal cells you have compared to the normal cells. So that's something that will be requested at one time or another, and unfortunately there is no other way to do that better. The other methodology that is frequently used is to quantify the monoclonal protein that is produced. And the methodology used is the serum protein electrophoresis. So it's you take blood, you eliminate the cells, and you just keep the liquid, which we call the serum, and then you deposit this liquid with a dye in a gel. The gel is really like a jello in like that, and then you apply an electrical current, and the protein will separate from the minus to the plus based on their charge and their size, because they are all of different size. And what you observe then, it's the profile like is on this graph here, which is the profile of the proteins of your blood, of your serum. So the most abundant is the albumin, and then you have the alpha 1, alpha 2, beta, and gamma region, where we have some major proteins that we already know. And the antibodies or immunoglobulin are found in the gamma region most of the time, but you can find the free light chain, for example, in 50% and more in the beta region, and also the IgA, the immunoglobulin in this beta region too, which can cause some issues when you want to quantify, because you also quantify the transferrin and beta lipoprotein and other protein in that region. When you have a monoclonal protein, here is a normal profile, when you have a monoclonal protein, then you can see it in the gamma region here in this example, you have a very high peak and a band on the gel that you can quantify, and it allows you to know exactly the amount of protein, monoclonal protein that is produced by your disease, by your plasmocytes. That's the way to follow your disease. But the problem of the serum protein electrophoresis is that it's not sensitive enough to quantify correctly the free light chains. And here in this example, you have a gel where you have a normal profile here, and all these other are multiple myeloma patients, and it's very difficult to identify one band to quantify compared to the normal profile. But if you look at the free light chain level, they are all abnormal and sometimes very abnormal, but we are not able to quantify that on the electrophoresis. So that's the reason why we have developed this assay in the area of the 2000. It's the Freelite immunoassay. It's based on a polyclonal antisera made in a sheep and directed against free light chains and directed against a region here in yellow that is in between the free light chain and the EV chain. So it's you have some epitopes on the free light chain that are not accessible by the polyclonal sera when the light chain is linked to the EV chain. But when the light chain is free, you can quantify these free light chains, and you can have the kappa light chains and the lambda light chains, which gives you three numbers. It gives you the kappa, the lambda, and you can calculate the ratio. And if you compare to normal values that are known and that were validated, you can see if you have abnormal or normal level of free light chain. So just to illustrate that, here is an example of a patient that was at some clinical details provided. It was only fatigue, which was not very specific. And on the electrophoresis, there is no monoclonal protein observed on the SPE. But if you look at the serum free light chain, here you have with the color, low is dark blue, normal is light blue, and gray is high concentration. You can see that for the kappa, it's 15 milligram per liter compared to the normal value, it's normal. The same for the lambda, it's normal, and the ratio is normal. So based on this result, yeah, there is no evidence of a monoclonal light chain for this patient. So apparently this patient is not a patient with a monoclonal gammopathy. The opposite in this example, you can see for this patient that has back pain and fatigue at diagnosis, that there was a monoclonal protein detected on the serum protein electrophoresis. And if you look at the serum free light chain, it was really high for the kappa. It was normal for the lambda, and it was the ratio then is very high. And so you can conclude that for this patient, the free light results indicate a monoclonal gammopathy with a free light chain kappa. And for the last example here, it's a patient with a present to the doctor with a fatigue and bone pain. There was just a faint monoclonal protein observed on serum protein electrophoresis. But if you look at the serum free light chain results, you can see that the kappa were very low and abnormally low, which correspond probably to an immunosuppression, which happens when you have a lot of plasma cells in the bone marrow. You can see that the lambda are very high, and then the ratio, because the ratio is kappa on lambda, is very low too. So for this patient, the free light indicates that you have a monoclonal gammopathy with a free light chain lambda. So that's the way you interpret the result together with the other, with the clinical picture and the other test. That's the way you can interpret the result. Now, to my third part, what is the utility of the free light chain? Because we already know that it's present, but why is it so important for your disease? So first of all, I already told you a little bit later previously, the serum protein electrophoresis is not very sensitive. At diagnosis, for example, if you look at all multiple myeloma, it can detect 88% of multiple myeloma at diagnosis, and when you know that at diagnosis, most of the time is where you have the highest level of monoclonal protein because the patient has never been treated. Most of the time when you go to the diagnosis, it's because you have a monoclonal protein. And in 88%, you are able to detect multiple myeloma, only 66% for AL amyloidosis. So the SPE is not sensitive enough to diagnose all multiple myeloma. If you have an intact immunoglobulin multiple myeloma, in 97% of the case, yes, we are able at diagnosis to detect the monoclonal protein. But if you have a light chain multiple myeloma, then it's only 61% of the case where you detect the monoclonal protein. So as I told you before, the electrophoresis is not the assay to follow and detect light chain. And then if you have a non-secretory multiple myeloma, SPE is useless because you are not able to detect anything for the patient with non-secretory or oligosecretory multiple myeloma. However, in that situation, in more than 70% of the case, you are able to detect a light chain for these patients, which is pretty important for the patients who have this kind of multiple myeloma. So if you add the serum protein electrophoresis and the Freelite, if you add the Freelite to the serum protein electrophoresis, instead of having 88% of detection of multiple myeloma, then you go to 100%. And it has been demonstrated by the Mayo Clinic in 2009 by the group of Katzman. So doing that at diagnosis is something that is very important because you will be able to have all your patients and not miss any patient. The same if you have amyloidosis, in 96% of the case, compared to 66% if you are using only protein electrophoresis, you will detect the disease. So that's why you need to add a very sensitive assay at diagnosis. Now, to monitor the response to the treatment, the Freelite, and you will see that in my next slides, is also very important, and I would say more than important, necessary to add to the other assays. It's very important for the clinician to adjust the therapy depending the response to the treatment, because the response, if you assess the response very quickly or not, then you can adjust or change the therapy. And as you know, the multiple myeloma is more and more a chronic disease. So you are treated and you go in a remission, but during this time you are in remission, you are followed to see if at one time or another you have a relapse or regrowth of the myeloma cells. And the Freelite chains, it's a very sensitive assay that can help you to detect the relapse earlier than serum protein electrophoresis. And also, why use Freelite is also to be compliant to international guidelines and to Canadian guidelines that have been published this year, because they recommend the use of Freelite to monitor, to diagnose, to monitor, and to have a prognosis of this disease. So what are the guidelines say this currently? In fact, if to be diagnosed as a multiple myeloma patient, you have to have more than 10% bone marrow plasma cells. That's the first thing, assessed by bone marrow biopsy, of course. And you have to have one myeloma defining events. What are myeloma defining events? Initially, before the guidelines were revised, you have only the CRAB symptoms, and the CRAB symptoms were hypercalcemia, which was indicative of issue with your bone, renal insufficiency, anemia, and bone lesion. That was the four criteria that are symptoms that usually affect some of your organs. So it's not nothing, these kind of symptoms are pretty huge symptoms. So that's why when they revised the guidelines, they introduced some myeloma defining events, which are the three on the black box. 60% of clonal bone marrow plasma cells, it's a risk to develop any of these wines. So if you have just that, but nothing else, no other symptoms, you have a risk to evolve and to have a crop symptoms at one time. So to avoid that, if you are diagnosed with more than 60% clonal plasma cell without anything else, then you will be considered as a multiple myeloma patient and you will be treated as a multiple myeloma patient to avoid developing symptoms and this kind of bad symptoms with bone fractures and so on. The other myeloma defining event also is the Freelite chain ratio that should be greater than 100. So if you have a ratio that is greater than 100 and that you have a monoclonal Freelite chain that is more than 100 milligram per liter, then you are in this category of patients that are at risk to develop in the 2 coming years a multiple myeloma and one of these CRAB symptoms. And the last one is greater than one focal lesion looked by MRI. If you have more than one lesion, then you're also at risk to develop one of the CRAB symptoms in the 2 coming years and evolve in multiple myeloma. So that's why if you have one of these 3 events, you are considered as a multiple myeloma patient and treated as a multiple myeloma patient. So the other interest of the Freelite chain, as I told you earlier, is to follow the response to the treatment. So it's based on the fact that the half-life of the Freelite chains is shorter than the total immunoglobulin or intact immunoglobulin. What is the half-life of a protein? It's the time that is needed to reduce of 50% between the time it has been produced and the time it has been destroyed by your body. And the kappa Freelite chain and lambda Freelite chains are destroyed in 2 to 6 hours. It's a matter of hours between their production and their destruction. If you look at the intact immunoglobulin, it's 5 to 7 days for IgA and IgM, and it's 20 days for IgG. So it's a matter of weeks for when you talk about immunoglobulin. So what is the impact of that on the follow-up of the treatment, of the monitoring of the treatment? Here is an example where you can use these differences. You have a patient here with the IgG kappa monoclonal protein. And you can see in blue that the Freelite chain kappa is pretty EV at the beginning, and the IgG intact immunoglobulin also. But when the patient is treated, Rx1, Rx2, you can see a very rapid decrease in terms of days, in terms of weeks for the Freelite chain, but you don't see this decrease as fast for the intact immunoglobulin. As you can see here, you are about more than 6 months after the beginning of the treatment, and you've reduced the percentage of intact immunoglobulin of only 50% when it has been done in a few weeks in the Freelite chain. So very quickly, the physician will have an indication that the treatment is working on the patient because the Freelite chains are growing down very quickly. So it's a very good indication, and you can think that, yes, probably the intact immunoglobulin will also follow. And if you look at that point here, you have at 0.1% of the plasma cells in the bone marrow, which means that we have been able to destroy the monoclonal, the bad plasma cells and causing the tumor. The treatment has been efficient to destroy that because you have only 0.1% of plasma cells. But still, you have a lot of immunoglobulin that are present in the serum because they were produced before the destruction of the cells, and they are still there because their half-life is really very long. So that's why it's interesting to look at a free light chain to see rapidly the efficiency of a treatment and to adapt the treatment to your disease. Then why it is important to follow your disease with the free light chain as well? It's come from also from this publication from Zamarin. Your disease is not homogeneous. You have to know that your clone, your monoclonal protein is produced by an heterogeneous clone. So you have more than one type of cells in that. And if you look at this study done by Zamarin, I said, at the beginning, at diagnosis, you can see that 22% of the patients that were tested in the study were producing only free light chain. In 68%, they were producing free light chain and an intact immunoglobulin. And in 10%, they were producing intact immunoglobulin only. But at relapse, so all these patients were treated, response to the treatment, and then in the study, they look at the relapse of the patient, the type of relapse they have. And the 100% of the patients that were free light chain only are still free light chain. However, if you look at the next population, the 68% patient, 22% of them producing only free light chain and are no more producing intact immunoglobulin, and 40% stop to produce free light chain. And the 38 remaining percent still produce free light chain and intact immunoglobulin. And if you look at the last one, 17% of this population start to produce a free light chain, which means that 44% of the patient changed their monoclonal protein type or monoclonal protein production during the course of the disease, which is underline the importance of following your disease with more than one type of assay, not only protein electrophoresis, but also free light chain to be able to detect this change in your clone. And what you want to detect is this light chain escape. That's this phenomenon where you have a rising monoclonal free light chain production at relapse without increasing the monoclonal intact immunoglobulin. So here you have an example of a patient with an IgA lambda at diagnosis, and that was treated. And you can see that at the beginning, the IgA in green is pretty high, the IgA lambda, and you have also the lambda free light chain that responds very quickly to the treatment. But both finally respond to the treatment and go to a normal value. So both the IgA lambda and the lambda free light chain were become normal. But after 1 year, what happens? The patient relapse, but he relapse not with the IgA lambda, but with the lambda free light chain only. So if you were following this patient only using the the serum protein electrophoresis, you could have missed this relapse with free light chain. And it's not a rare phenomenon. The light chain escape is something that is about 10% of multiple myeloma. And if you have an IgG multiple myeloma, it's about 6.5% according to the publication from Braioli. It's about 6.5% of the case where you have an evolution of the disease with a light chain escape. But if you have an IgA multiple myeloma, it's about 20% of the case that you can evolve in a light chain multiple myeloma. And just to mention here, because I will come back after that, if you use the quantification of free light chain in urine, what we call the urine Ben-Jones protein, if you are using urine to quantify the free light chain, you will miss this light chain escape in 50% of the case. The other point that I want to underline here is the importance when you follow your free light chains is the importance of the level of the free light chain. you can classify the response of the patient based on their free light chain, for example. And usually what the physician wants to achieve is the best response. So able to achieve a complete response or a stringent complete response. A stringent complete response is a response where you normalize, it's a complete response where you normalize your free light chain level. And why it is important? It's because you have some studies showing that if you look at this curve here, it's stringent complete response. These patients are an overall survival that is better than the patient who did not normalize their free light chain. So these patients were not normalizing their free light chain, but those who were normalizing the free light chain have a better overall survival. And if I go a little bit further, in this population of patients that normalize their free light chain, you have those who normalize and sustain this response, and those who normalize but not sustain this response. And in patient who sustains, it's even better. The overall survival is even better than if you don't sustain the normalization of free light chains. So that's a very good biomarker of your disease and a very prognostic marker also of the survival. And that's why I think it's pretty important to have this data in mind and to be able to follow them during the course of your disease. Now, you can have some variation in your result from one type to another that you have tested. And this variation could be to many things. So I think it's important for you to know that you have a normal biological variation that is of 20 to 30% per day, which means that if you have tested in the morning or you are testing in the evening, then you could have different result, and it could be a difference of 20 to 30%, which means that if you have a difference of 20 to 30% between your one free light to another, I would say don't worry. It could be due to the biological variation. It's not a result on itself. You don't have to be frightened about this kind of variation. The other thing is that your test could have been done on another instrument. That could be done in another laboratory too. So that's the kind of things that can happen. So you never know. In the lab, they could have different instrument, or they could have changed their instruments. So then it could involve create a difference between one result from another. The same if you are traveling, you can be sent to another physician that will ask for free light chain, but it will be done in a different laboratory, and then the result could be a little bit different when you are using to do or to see, and it explains the variation you can see from one test to another. It's not always related to your disease. It could be related to the analysis. And a third point that I've not mentioned here is also that it can be done with another test that is not Freelite, because there is all other serum free light chain assay on the market. And these tests are not recommended by the Canadian and the international guidelines, but there are some labs that are using some other tests than the Freelite, and then you could have very different values if the test that is used is not the Freelite. It's important for you to know it. And the thing that is important, if you know that you are a patient that has been tested with a new test or a new instrument, probably it's important for the physician to give you a new baseline of your disease. Otherwise, you will have a drop and you will not understand it, or an increase and you will not understand it. Importantly, also to understand your lab result is, as I show you at the beginning, is to compare your result to the reference range, or in what we call also the LC individual range. It's important to compare to these values to know if you are outside of these ranges. That's where you can say, and you can see how far you are from this, the normal ranges also. That's pretty important to compare to that. But also very, very important, it's to interpret the result together with the symptoms and together with the other tests that are done, because one result alone is not enough to be comfortable with the diagnosis or a conclusion or clinical conclusion. And very important, and you can do that, every patient can do that and should do that, is to look at the trend of your result from one time to another. If possible, use a graph and follow the evolution of your results from time to time, and bring that to your physician, because sometimes they are not looking at the trend as carefully as you could do. And so you can ask a question to your physician to understand why I am stable, or why I'm decreasing, or why I am increasing. And it's pretty important to bring this kind of information to your physician and to ask questions when you don't understand things, or if you don't understand their answer to. So now my last point is why urine? Yes, because your doctor frequently ask for urine at one time or another, will probably ask for a urine test. And the fact is that they want to see if there is some proteinuria and look at the kidney damage. Most of the time, it's to look at that. Do you have some Freelite or intact immunoglobulin in your urines? Because it's absolutely abnormal, and then you have some kidney damage. And in 50% of the multiple myeloma patient, you have some renal insufficiencies. So it explains why they want to see that. But there is many other way to look at the renal functions than look at the intact immunoglobulin or free light chain in the urine. And why it is better to look at the free light chain in the serum is for three main reasons. First is the analytical sensitivity of the Freelite assay, the renal metabolism, and the urine compliance. And I will go through these different points. So first of all, the analytical sensitivity. So if you look at the Freelite assay, it's the only assay that can give you the normal range of the free light chain in your serum. None of the other assays that are used, even in urine, are able to give you the normal range. So when a test in the urine is negative, it doesn't mean that you are in the normal range. It just means that you are not abnormal, which is not exactly the same answer. So the free light chain is more sensitive, 10 times more sensitive than the urine, and 500 times more sensitive than the electrophoresis. So that's why it's pretty important to have this assay in your arsenal to follow your disease. The second part is the renal metabolism. So the renal metabolism is something, well, in fact, the free light chains, I told you that the half-life is about 2 to 6 hours. It's because the free light chains are filtrated through the glomerulus. The glomerulus is this part here is the schema of a nephron, and the nephron is just one unit of your kidney, and you have millions of units in your kidney. But each unit, what they do, they filtrate it through the glomerulus and to eliminate what is bad in the urine and reabsorb and destroy eventually what is good for your body. And so the free light chains are filtrated through the glomerulus. They are reabsorbed in the proximal tubule here and destroy after that. But what an healthy individual is producing per day is 0.5 to 1 gram per day of free light chain. But the capacity of the proximal tubule to reabsorb protein is between 10 to 30 grams, which means you have a lot of room for absorption or reabsorption and destruction of the free light chain before they spill off in the urine and before you find free light chain in the urine, which is the reason why it's more important, it's more interesting to look at the free light chain in the serum than in the urine. And you have some example of that where you can see here patients where you have absolutely no information in the urine when you follow the free light chain, when you have a very huge variation in this case of severe osteolytic lesions that you can see, but nothing is seen in the urine. The same here during the treatment. You have nothing in this patient, but you can see a decrease of free light chain during the treatment, which was not the case with the urine. And finally, and I think it could be the most important part, is the urine compliance. Here you have a summary of all the publications that have been done on the subject, showing how the urine are compliant in clinical trials, in studies. And it has been shown in all the studies that the urine were not compliant. Usually, what is asked is urine, 24-hour urine. That's what the physician usually asks you to provide. But most of the time, it's what is provided. It's 16, 18, 20 hours, sometimes less, and sometimes not provided at all. So if you summarize all the studies, in 2/3 of the cases, the urine specimens are not of good quality. So if you don't have good quality specimens, you don't have good quality results. So it means that following the free light chain with bad specimen, it's not a good idea to be accurate. So that's the three reasons that is in favor of using free light in the serum instead of in the urine. So to summarize my presentation for today, I want to recall you that the free light is recommended in the international and in the Canadian guidelines at diagnosis, for the monitoring, and in prognosis. So that's why you should have this result available for your disease at one time or another, and it's possible all the time. At each visit, you would have this result provided. And the reason why it's recommended in the guideline is because it enhances the sensitivity compared to the serum protein electrophoresis. I show you the serum protein electrophoresis is not sensitive enough to detect correctly the free light chain. And it's very important for the physician to evaluate rapidly the response to your treatment and possibly the depth of the treatment in the future. So what we call the minimal residual disease, for example. And it's pretty important to have this information, because you can react and you can probably change the treatment or adjust the treatment based on the evaluation of the response to the treatment. It's superior or equivalent to the urine analysis as we saw just before, and it will help you to detect light chain escape. And this point is pretty important, because if you relapse, when you relapse with free light chain, it can relapse very quickly. So it's important to detect it as fast as possible. And also, as I mentioned you very quickly in one study, but there is many other studies showing that the serum free light chain level and the normalization of the serum free light chain is important for your survival, or is indicative of the prognosis of your disease. So with that, I hope that things are more clear or clearer for you for the free light chain. And if you have a question, I'm here.
Thanks, Frank. That's lots of information to digest. As I mentioned earlier, the webinar is recorded, so you'll be able to see, go back and look at some of the slides that maybe you need to look back at one more time. So the first question we have here has to do with, for example, someone who has IgG kappa myeloma. And after treatment, the kappa light chain seems normal, but then all of a sudden the lambda is very low and the ratio is elevated. So what exactly does that mean? If you have a kappa disease, but then it's the lambda that's super low.
Yes, it's very that's what I show you in one of the example. The kappa was the opposite. It was a kappa that was very low, but the lambda very high. In fact, in the disease, as I explained, how it works. When you have a lot of plasma cells in the bone marrow, you have no room for the other cells to grow, and then you reduce the other type of plasma cells. So you can have a reduction, and it's what we call most of the time immunosuppression. So you have a suppression of your immune system globally. So you have a suppression of all the polyclonal kappa and the polyclonal lambda, and that's where you can have very low kappa, very low lambda if you have a kappa disease. So you can see a very low lambda and but a very high kappa. And for sure, if you divide the kappa by a low lambda, then you increase a lot the ratio. And that's the main explanation I could see in that. But again, you have to see all the clinical picture to answer correctly to that.
Thank you, Frank. So the next question has to do with again with the ratio. So someone relapses, the ratio goes high up. Then treatment, the ratio goes back to normal. Like what does treatment always bring the ratio back to normal levels, or
No.
or
No, in
yeah?
fact, it's the objective or the target of the physician is to obtain the best response to it with the treatment, but you are not always able to go back to normal, and sometimes it's better to have an abnormal ratio that is stable than a very low ratio that is fluctuating, for example. So sometimes that's the target of the physician, is to have a stable kind of stable clone with the treatment. So not increasing, not decreasing, but stable. It's something that is sometimes the target of the physician. And of course, if you can normalize your numbers, as I show you in the clinical studies, most of the time it's a good indication. But each individual has a different response to treatment and a different disease.
Thanks, Frank. So our next question here, you had mentioned that that the Freelite test is recommended in guidelines both internationally and Canadian. These guidelines, do they recommend an ideal frequency? So how often should the test be given according to these guidelines?
Yes, they give some general guidelines, and it depends on the risk of the patient. So if it's a high risk patient, for example, because you have some diseases that are more risky than other, depending of the kind of mutation you have in your plasma cells. We know that some diseases are more aggressive than other. So for the patients for which the disease is more aggressive, they will recommend to test every month. For those who it's less aggressive, every 6 months at the beginning, and sometimes could be every year. But most of the times it's I would say, in average, it's every 3 months that it's tested. But for patients at high risk, it's more frequent than for the other. And the things that is important, and in many places it's done at each visit. And so what is is defining the number of visits in a year depends on the risk associated to the patient. So if it's every 3 months or every 6 months, for the patients, it's a lower risk that if you have to go to the doctor every month. So this this period of visits, that's what determines most of the time the aggressivity of the disease. And usually the physicians are testing the free light chain at each visit. That's what they are supposed to do according to the guidelines.
Thank you, Frank. So I guess the last question here, can is it possible that a treatment, for example, can can lower the free light chain values to the point that they're not measurable anymore?
Non-measurable anymore? I don't think so, except if you have no more plasma cells, because that in healthy individual you have the normal values, which means that if you have an immune system that is working properly, normally you have something that is measurable. But yes, if the treatment is very aggressive, or if after a stem cell transplantation, for example, where you kill all the cells before reimplementing the cells, the good cells, then at that time you could see very low level of plasma cell before the bone marrow is reconstituted. And that's where you can see that. But most of the time, if the person feels well, has no symptoms, and recover, then at that time you should see some free light chain level somewhere in the range of normal.
Okay, thank you. So I just got one little quick question as we were finishing off. Basically, is it possible that when people receive their lab results, sometimes the free light chain results are not there. Could that be because they're done by different labs, or there's a specific lab that does the free light tests versus another one?
That's possible, because the fact is that when you are in an hospital that send out the result, the test to another hospital, a reference hospital, at the time of the visit, sometimes the free light chain results are not yet available, so you don't have this result available. What we here at the binding site, what we ask most of the time is to have an answer quicker than 2 weeks. So when you have the sample from the patient, the results should come back before 2 weeks. But it's not always possible when you are in some area. I think about some region that are far from a center, reference center. Sometimes it's difficult to respect that, and then you could have more than 1 month before having the results. Sometimes even more than 1 month. So when you could visit your physician, but the free light chains results are not available, and they come after you have visited your physician.
Okay, thank you, Frank. So with that, we have no more questions, and we're out of time. So thanks, Frank, for taking the time this afternoon to come present to us. We learned a lot of information, and it'll live on the internet for a while, so that others can come and learn how to follow and understand their free light chain. So thanks very much, and have a great afternoon and evening.
Thank you. It's my pleasure.
Thank you. And right before we end the webinar, I just wanted to remind everyone that we have our next webinar is tomorrow. Our next English webinar is tomorrow with Yelek Biru, a patient advocate who's been living with myeloma for 25 years. It will be presenting to us. On our website, myeloma.ca, in the news and events section, click on info webinars, and you'll be able to register for that. I hope all of you can make it there. Thanks everyone for joining us, and have a great day. Bye bye.